So I'm Franklin Huang, I'm an oncologist down the street at Dana-Farber, also the co-founder and co-president of a nonprofit organization called GO, short for Global Oncology. So I'm very happy to be here today to share our work with you, with Carlos and me and a number of other people who I'm representing here today. So, to talk about a global health threat, I think that to introduce some of you to this topic, which may be unknown, is that cancer worldwide and in poor countries is killing more people than HIV/AIDS, tuberculosis, and malaria combined. And why is that important? Well, because most of the discussion over the last 15 to 20 years is really focused on the very important emergent and health human rights crisis that communicable diseases has inflicted upon poor countries. But this has really begun to shift, as well as that non-communicable diseases, of which cancer is the primary one, is killing more people, and that may not be an issue that is well known to the general public right now. And within these countries, what we call LMICs, but short for low and middle income countries, 70% of all cancer deaths occur in these countries. But the great disparity is that only 5% of the global resources dedicated to fight cancer are being spent in these countries. And really, the problem is only going to get worse. By estimates from the WHO, there will be 10 million new cases of cancer every year in these poor countries that are least equipped to fight cancer and that are vastly underprepared for the growing burden. So here we'll talk a little bit about the challenge that we faced and how we sort of addressed it. And so our story really begins in Malawi, where GO, the nonprofit, partnered with a hospital, central referral hospital called Queen Elizabeth Central Hospital, that serves millions of patients in Haiti, to really improve clinical care by supporting clinical decision making. And we did that by hosting case conferences with them, and we heard the experiences of both nurses and physicians who told us about patients starting to experience side effects from chemotherapy and getting their treatment, but then stopping treatment due to the effects that chemotherapy was having on them. And so what we began to learn through their experiences and their feedback was that one key factor that seemed to be undermining the outcomes of patients in Malawi was a lack of knowledge by the patients. And so we embarked on a project out of that conversation to create an educational tool to facilitate dialogue between patients and care providers, and with the goal of promoting adherence to chemotherapy by helping patients understand their disease and their treatment. Things that we often take for granted here because we can quickly go onto our phone or go on a computer and search for endless amounts of knowledge about cancer, what one might expect. But you can imagine a person who lives on $2 a day with no access to that type of information is extremely limited in what they can learn. So our goal is to disseminate this tool to cancer patients in low resource settings worldwide.
So some of the early lessons in terms of as a design collaborator in this process, what were the parameters that would matter the most? And one of the things that from those early conversations stood out had to do with how do you create a tool that could be easily adapted and distributed, that was low cost, that was easy to reproduce, that would also naturally integrate with the workflow of practitioners. That was not something that would be burdensome or cumbersome, already stressed out, limited time and limited resources. So another important factor had to do with the literacy level of people that are going to be receiving these materials. And what were aspects of how much they could actually engage with that information and understand complicated terminology, as well as what are cultural considerations of how they understand disease, how they understand medical treatment, what does that mean, what were the best way to illustrate complicated aspects, for example, like symptoms or side effects. So really tapping into those questions, and then particular logistical constraints. How is this actually shared and distributed? How are they actually located physically in a hospital or in a clinical setting? What is the potential life cycle of these objects? Who owns them? Who's going to share them? Who's going to guide the conversation? So these were the initial questions that we, as a design perspective, were able to translate to parameters, and we started discussion of what would be the best type of solution that could be developed.
And so some of the challenges that we encountered in Malawi are not unique to Malawi. They're common to other low resource settings. And some of the challenges that we have come to understand from our colleagues and partners on the ground are what Carlos mentioned of literacy, the low literacy levels that can create a barrier to treatment and care, the tremendous human resources insufficiency, staffing, so that teams are often treating a large number of patients with very little time to explain symptoms and side effects. And then resources. I think obviously all these locations often lack resources, and what we learned was they lack these tools to help support everyday communication with their patients. And here we're showing you 3 sites where we are currently collaborating on these materials. And this is in Malawi, Butaro, Rwanda, and in a hospital that Lori Chandra will talk about later in Haiti. So just to give a brief introduction about Global Oncology, we are a nonprofit organization that was founded 3 years ago, and our mission is really to bring the best in cancer care to underserved patients around the world. And to do this, we collaborate across a number of different borders to improve cancer care, research, and education. And our goal is really to impact diagnosis and treatment and improve outcomes by building sustainable, scalable, and creative programs. You can learn more about us by searching for us on the web, but among the 2 main programs that we currently feature is both the materials and booklet that we're describing here today, but also a global cancer project map, which is designed to tell people who's doing what and where in low and middle income countries so that we can catalyze collaboration. Because as you can imagine, there are many groups working in global health, but who's doing what and where is often a problem and a challenge.
And a little bit about the NIM and how we enter into this process. So we're a strategic design and innovation consultancy here locally in Cambridge, and a lot of our work has been focused on creating really engaging experiences for different types of organizations, mostly corporate clients. But this was a really interesting opportunity. This project brought a different type of potential applications of our design process, where we were thinking to bring a lot of the human-centered design approach to this collaboration, and thinking about how our work could create impact from a different perspective. How could we be engaged in designing for social impact? How could we leverage the potential for design to support this process in translating all this knowledge, and how we become a bridge between different participants. So this is sort of our interest came from how can our work be changed, and how can our work help change, help affect the change that global oncology is bringing to the table. A little bit of an anecdote of how we met. We ran with each other in a healthcare conference. I have a person interested in oncology as well, being a former patient, but in conversation, very organically, we found a lot of commonalities, and we saw a potential group that was interested in design in a different way, where we thought this would actually help us rethink how we do design. So there was the reason why we got engaged in this project.
So we'll talk a little bit about the collaborative design process that we undertook. And so when we think about this, what our goals were, as an oncologist, and thinking through what the patient experience is, we thought about what is an important thing for a patient to understand, to help guide them through what is going to be the most difficult treatment that they will undergo in their life, and life-threatening illness. And so we think about very clinical issues, such as how can we help them prevent common infections, what should a patient understand about their disease, and how can patients take better care of themselves in a setting where their resources are extremely limited. And when we think about what patients want to know, we had to make certain assumptions based on the experience that we have here as oncologists and taking care of cancer patients. Patient might wonder, is what I'm feeling normal? What should I do in an emergency? Here we take for granted that we can call 911, go to the emergency department. That's a very different situation when you live in a rural village, and that's not a possibility. And then how should the doctor and the nurse communicate with the patient? These were all sort of questions that informed our understanding of what that knowledge gap might be, and what is the type of content we should build with Carlos and his team in terms of communicating that to patients in low resource settings.
So when the conversation started, we started to understand the complexity of the process and a lot of the nuance from translating all the important and high-level discussions that were happening. At the same time, the very practical situations where you need, as a designer, to control how are these questions best answered. And here's a bit of a picture of how the process, the different phases that went through, and how this is almost like an iterative cycle. The first step was starting to build some knowledge. So looking into what materials are available that describe both education materials for cancer, as well as what is the literature thought saying about what are the other researchers and designers doing with when we have to deal with low literacy. And obviously dialogue with people in the field, in the actual location that can describe their own needs much more effectively. After that, there became a phase of developing the content. So what are the actual team in the US, both the global oncology team and other collaborators and partners that will help you define the scientific language and the type of content that should be involved. And then how do you evaluate for low literacy, bringing experts? How do you create professional translations, as well as sending some drafts into the field to look at cultural relevance? Is this going to be accepted and understood? With all that feedback, particularly with the local feedback, then became the more serious distribution of the materials in the wars. Testing to set the expectations and test the initial parameters, and then developing a much more rigorous research and a much rigorous evaluation of the actual designs and the actual efficacy of the tools to contribute in increasing the knowledge and improving care. And something we'll touch upon in the specific case of Haiti. At each of these three steps, there was always back to design. How do you design actually encompass this content, create a document, or whatever the tool is. In this case, it's a document. How do you create an illustration and a visual language that matters, that is culturally appropriate, and how do we create a tool that is extensible, expandable, and works? So, to talk about those first steps, the early materials that were being looked at were, of course, medical materials that were highly technical in terms of describing the science of the disease, using a lot of the scientific language and with very, very elaborate illustrations, and that were explaining both symptoms and causes as well as side effects of treatment. So a first set of drafts of the initial content that, particularly through discussions in Malawi, which was the origin of the project, the decision was to focus on one particular condition, which was lymphoma, and then aspects of treatment, including side effects and self-care. So that was the origin of a schematic set of content that would make sense and would be top priority for this location. And from that initial moment, initial draft of how to distribute this information, how do you make it more visual, more user-friendly, how do you actually create visual cues and visual materials into this solution that would help identify the people who are going to be looking at this with low level of literacy, as well as with the scientific team or the practitioner team in the field. The decision was to create a physical booklet that could be easily photocopied and that could be distributed in this location that require very low technology to be developed as a starting point. And these were just the first ways to lay out the content, to start to think about illustrations. Should we illustrate the whole body and point to potential areas where the disease lives, areas where the symptoms might be affected? How do we illustrate these problems and create tools for assessment? These initial drafts were shared with professionals here in the US, but also in Malawi. So the first evaluation had to do with the language. A professional from Dana-Farber Cancer Institute took a look at the level of literacy that the language was appropriate for a low level of literacy, and simplifying the terminology and providing some guidelines for the team to move forward. And then nurse practitioners in Malawi looked at the initial draft of the illustrations, but in particular the content as well, especially looking into the cultural context. How would people really interpret these images? With the iconography or the way to illustrate that was chosen speak the same way that speaks to us here? Are the references the same, etc., etc. So after several rounds of conversation, the global oncology team, assessing both how to bridge that knowledge gap, but to keep some of the rigorous descriptions in terms of the science that wanted to be explained, took a step back and decided a set of content that was a little bit more generalizable. So it went from a lymphoma-specific tool to a tool that would be providing general questions of cancer, talking about side effects and providing some tips for better self-care, going from assessment on how to ask for help to actually ways that once you're outside of the clinical setting, help you keep track of how you're doing. So this consolidated the content, and we started iterating how to better design for that. A couple of rounds where we started experimenting with simple things, just changing the layout and the format of the document to make it easier to reproduce, a better distribution of the material, both in terms of text-intensive areas and more visual-intensive areas that could facilitate certain type of dialogue around the content. Particular use of coloring, so we can create different categories and expand the content if you wanted. Ideas about the appropriate visual language, so changing a little bit of the illustration and to make it more specific about particular symptoms or side effects, and developing different types of potential places to record information that could be valuable over time. So a few rounds of this went back and forth both locally and in both Malawi and Rwanda. At this point, Rwanda was another location that was involved. And this was the first time that these booklets that were taking shape were in the hands of providers in the field. We're getting mostly feedback from care staff in these locations. A lot of questions asked in different ways, informal interviews, conversations, very small focus groups with clinicians and a few patients, focused mainly on the quality of materials themselves. Is this clear to understand? Is it helpful? Do you get language, etc., etc.? I think those conversations started also being informed by how people were actually using these materials, observing where they live, what happened to the materials, discovering that there was interest in taking the materials outside of the clinic to be shared with families and other caregivers. So all this observation and understanding the way that they could be used, how hectic an environment can be, and how this needs to be something that helps in that process of providing care for these populations. And a set of recommendations specifically applicable to design, the design process came in the form of the material itself and specifically the illustration and the content. In terms of the content, I think it spurred a lot of interesting conversations that came back to the oncologists and professionals here in the US that we'll touch upon a bit later. The first step, obviously, is a translation, so professional translators through partners, I think Partners in Health helped with some of these translations to create, obviously, local language versions of these materials, both for Malawi and Rwanda, and then all this process led to the final version of the booklet that is now being piloted around the world. It's still an 8-page modular graphic design of a booklet. We strive to simplify the design both in terms of clarity and simplicity, simplify the type of text that's being used, the relation between text and visual language. The use of font was also strategically clarified in terms of being able to make it easier to read, as well as the type of illustrations. The content was focused again on basic information about cancer care and chemotherapy, but particularly focusing on the monitoring, self-monitoring and self-care tips and considerations. So the intention here was to actually facilitate those conversations. This was less about providing sort of a Bible or an instruction kit. It was more about making these tools something that could be used by providers in the field to describe particular symptoms or side effects, to bridge the idea of what to expect the knowledge of patients to be, and in those conversations discovering things. The same thing we're recommending what type of symptoms would be something that would set an alarm and for action to be taken. I know you want to have some.
Yeah, I think that one of the things that we wanted to do was try and help both patients and providers think about what are the things to look out for. I think it's very, we obviously had to make some assumptions and hypotheses about how to guide those conversations and what are the symptoms and the types of imagery that would be helpful in doing so. And I think that, this was something that we responded directly to what we heard from our partners in the field about what might be helpful in terms of guiding those conversations and guiding what nurses felt that they needed to tell their patients about.
So the other side of this was out of the clinical setting where that conversation obviously was not going to happen, but the time where the patient was by themselves or with their families, and the sense that there was something that they could take home that made them feel safer. Sometimes this idea, those conversations would extend to the home setting, and actually sort of trying to create some aspect of behavior change. making the patients more aware of what they needed to be more conscious of, how they could keep track of some of the ways that they were feeling, even extending some of the symptoms that were not illustrated here, but this idea that they were allowed to think about this and could create a record of how they were feeling, so when they came back to the clinical setting, they could actually have those conversations again. And on the other side, also helping family and other members of their inner circle provide better care for even themselves. Tips of very simple things that matter a lot in this context that would help them mitigate and have a better quality of life as they go into treatment.
Yeah, and I think that we really wondered about the fact that side effects that, and we always ask patients when they come into a visit after getting a cycle of chemotherapy, did you have this, did you have this? I mean, I think that enabling them to think about these issues and circling on this, and this is still a process in development, but how to ask patients to think about the side effects that they're having, how to record those, and initiate conversations between them and their family members to help them think about what are the issues to pay attention to, what are they struggling with, and what might improve their quality of life while they're undergoing this treatment.
So just to zoom into one particular aspect that was really interesting, and you're seeing the beginning and the end, but there were a number of iterations on how to express a simple thing like nausea or a simple thing like fever, and what is the right iconography? How do you create something that is simple enough to understand, it doesn't need a lot of additional signage or external information to describe it. So we went through from a very abstract icon-based language that tried to simplify and avoid or prevent any additional meaning with very simple type of drawings to a more detailed and realistic visual language that brought us closer to thinking about how do we bridge this gap between low literacy and cultural relevance. So in that case, we took a bit of a very conscious strategy in terms of trying to create drawings that were not only very clear in terms of making the materials easy to reproduce, but also that would provide very simple tools to create understanding. So the idea that with body language and facial expression, where there was no facial expression, it was hard to understand where there was an emotion. Here, emotion played a role in really expressing a sense of relief or a sense of pain and discomfort. And the lack of shade or the lack of coloring to prevent any unintended highlight of parts of the body, or even thinking about unintentional meaning, because colors sometimes have different interpretations around the world. And in terms of cultural relevance, what would be aspects where as people look at these images, they could see themselves and identify themselves within a culture, but at the same time providing enough diversity that this could be distributed in different settings. So we chose to base the illustrations on different ethnicities, as well as providing in a few illustrations some garments that were typical of certain regions where this was starting to be piloted, or particular relevance to certain types of weather conditions, etc. So this was very consciously done, and I think that it provided some important cues as we move forward into doing research and evaluating some of these aspects of translating that material into visual representation. Where we are right now. We presented to you how this is a challenge in terms of global health, how low literacy is one of the key challenges when you think about cancer care in low-middle-income countries, beside all the lack of resources. The process beginning in Malawi and the data setting in the allocation becoming the sort of the starting point for this process. Early pilots and iteration in both Malawi and Rwanda, and now a long, lengthy collaborative process over time that led us to this version of the booklet. So we want to talk a little bit about how now the whole team is working towards creating a process that is replicable and to assess and evaluate. And the first example of this is pilot behavior. So I'm going to invite Lori to tell us about that story.
Hi, my name is Lori Schleimer. I'm a student at Harvard Medical School of this week. How I painted this picture is I met global oncology and the meme at the same time as I was having conversations with the people at Dana-Farber and Partners in Health who run the cancer program in Haiti. So in Haiti, back in 2010, most of the nation's healthcare infrastructure had been concentrated in the capital, Port-au-Prince. And if you were a cancer patient back then and you didn't either live in the capital or have money to travel to the capital patient after patient come through with cancer and having nothing to offer them. So she essentially built their cancer program from scratch. She has collaborated with oncologists in the United States and received funding from some humanitarian organizations to start providing cancer treatment. And they do, every Friday, they have an international conference call to talk about patients and come up with treatment plans together. And she has, over the last few years, there's just been an overwhelming increase in the number of patients that are coming in because there's so much need in this rural location. And unfortunately, there's no one to fill her shoes. You know, she never completed formal oncology training, and she would love to do a fellowship, but if she were to leave, her patients would be really left without any options. And I wanted to share a story of one of her patients. I'm going to change the name to protect privacy, but this patient is Marie Louise. She's a 56-year-old woman living in rural Haiti, completed a second-grade education, and for income, she runs a small store out of her house. And she says, there are people who say if you hit part of your body, that part can turn into cancer. For me, it just happened. Without hitting my breast, I saw that I had a little lump inside it. My son took me to the voodoo priest's house because he thought it was a woman in my town that had put a curse on me. People showed me home remedies, how to rub my breast with mistreaty oil and wrap it up, but the lump grew. It grew and burst and made a sore. It bled and bled. I went to see the doctor and they gave me medication for a month. It just got worse. They got to the place that it started to have maggots. Now a different doctor came to find me at home and they pulled out the maggots. After that, they told me they would take me to Mirabelet to get treatment. They told me it was a disease called cancer. So when Marie Louise and patients like her come to Mirabelet, they have a biopsy taken. That biopsy is sent to the Brigham to be read, and then a month later they'll find out what the treatment plan is going to be. And her cancer had spread so far locally that they needed to do chemotherapy before they could do a mastectomy to remove the mass. And what that means is, you know, she lives about 4 hours away from the hospital, so she has to travel there every 3 weeks. With chemo, you need to have her blood drawn the day before so that they can make sure that all of your levels are appropriate for treatment. And so she and most patients will actually sleep outside the hospital the night before they have chemotherapy. And when they're in there, there are more patients than there are chairs oftentimes, so they'll have to do 2 rounds, and really the need for this is so overwhelming. And in Haiti, they're facing a lot of the similar challenges that there were in Malawi, with just lack of knowledge, no idea what to expect from chemotherapy. So our goals for this pilot were, first of all, to bring the materials to Haiti so that patients like Marie Louise could have the same resource that we were starting to share in other countries. We also wanted to use this as an opportunity to formally evaluate the materials in a scientific and rigorous way to make sure that they actually are useful for helping patients learn. We wanted to gather data from both patients and providers to drive further improvements to the materials, and think strategically about, as we start to implement these in other low resource settings, what are some of the challenges and solutions we can find. So when I took the booklet there, it was honestly so overwhelming how important this was to these patients. They were so grateful to have this tool. They said, you know, I had all this information, it's important to me, I want to go home and study it, I want to share it with my friends and family so they can understand what's going on. Patients said, this booklet is going to help people know how to treat the disease and also how to live a better life with it. It's important, it serves to orient you, it tells you what precautions you should take. Then when you're on chemotherapy, what effects it will have on you so you don't have to worry yourself about them. And some of the challenges we had and lessons learned were really the importance of showing up in person. As you can imagine, for providers working in these settings, they receive a lot of email, a lot of promises of good work that people want to do, but they don't have time to sit around and respond to emails all day. So to actually go there in person with a translated version of the booklet and introduce it to the team was an essential first step. And the way that we went about it was in a very collaborative process. I sat down with all the providers and asked them what they thought to incorporate their feedback into the materials and make sure that it really met all of their needs. And that process makes the providers feel invested in it. They feel like they've had a part in creating this, and so it actually does get used after the fact. One of the challenges of introducing it in new settings is that you're never really going to have unique requests for additional content. And as Carla said, if we were to really put all the information in there, and it was like a Bible. And that's not the purpose of these. So we have to figure out which requests can we accommodate, and to what extent do we want to customize it when we bring it to a new setting. And ultimately, we learned that if as we want to ensure that there's continuity with this and make sure that the materials continue to be used, it's so important to identify a champion. for the materials. And that picture there is Peter Desimo, who's a mental health counselor, and he's the one that I worked most closely with to conduct all the patient interviews and implement the materials. So he's really been our champion in Haiti. So the current status of the materials is that they're being printed locally on site in Haiti and distributed to all patients when they receive their diagnosis and are being referred to the mental health team. This is an interesting thing that we've been noticing in Haiti because the nurses and the doctors are so busy in doing day-to-day clinical care, they don't always have time to sit down and spend educating patients. So to have this tool in the hands of the mental health counselors, they're the ones that really have the time to go through it with the patient and answer all of their questions. And for them to have this resource, it helps make up for some of the lack of clinical knowledge that they have just based on their background. And so we have ongoing communication with the providers on site to help troubleshoot any problems that arise in the future and make sure that they're still able to use them in a meaningful way. And as of now, there's a similar pilot ongoing in Rwanda.
Right, so you see the process all the way to how it's being implemented. I think it's a good point to step a little back and think a little bit more broadly about the collaboration. So, and some thoughts about how this process is teaching both the design team and also the global quality team how to move forward.
Right, and I think, this process was over a 2.5-year, almost 3-year process. It involved a number of stakeholders locally and globally. And, I think from GO's standpoint as a volunteer-based network, our goal was to share this mission and this goal with these stakeholders and get buy-in and then bring to the table talents and the resources that were available. I think everyone agreed on the shared goal of the materials and saw the value, the intrinsic value in them. And I think that went a long way in terms of helping to coordinate many, many people, many, many different opinions and preferences into what we ended up with in the end, which required compromise and understanding both the goals and the preferences of various stakeholders. So it really was driven by volunteers, and we really wanted to focus on impact. And then, this is part of our development as a nonprofit organization to really build networks that can improve diagnosis and treatment of patients in these low resource settings. So it was a really remarkable network of people and commitment by various different groups to really see these through. And it's still a process ongoing, but I think in most settings in which we've introduced these to people, there's been overwhelming enthusiasm to get these into the hands of providers and patients.
And so, in terms of the perspective from our role as designers, being the design team members, we're sharing all this process with different type of professionals. I think what we've learned is that design has played a very interesting role, and we've been sort of a catalyst. We've been able to become a sort of a funnel or a channel to bring these conversations together and anchor them in a meaningful way. At the end of the day, they become very practical issues, and some of the conversations are really valuable as they bring very critical questions in terms of having long-term impact to people's lives. And all these multiple voices that are able to be brought together, I think, facilitate a way we think about how to produce efficient and very effective tools to support the goals of this process. A very big part of this is making very abstract and very complicated topics very concrete and thinking about the best way to represent them. And also thinking about how to both synthesize the knowledge that is happening into the product themselves, but also how can we help expand the vision. And at this point, I would say, we can talk a bit later, it's really the context and the search for more resources where we see an opportunity for design to grow and expand this role. For now, we've been supporting this process with a very particular goal, a very effective goal, but one of the most important lessons is that I think we have a lot to contribute, and it's a way to encourage designers to think about that role in different settings as they move forward. A little bit about the future of the project and where it stands right now. There's questions that were interesting through the whole process and questions that are very relevant today. How do you make this scalable and how do you increase the outreach? So obviously translation to other languages, Spanish is going to be very important because many countries will be relevant, but then it becomes each country, we think in Latin America or in general, have very different ways of using Spanish. So it's going to be interesting to see how the different versions of Spanish are used and locally in different settings. Or other countries currently in Africa already been translated to Setswana to be able to implement in Botswana. So this idea of multicultural understanding is going to be very interesting, and Spanish obviously being able, for example, to be used here in the US as well. I don't know if you have any.
Yeah, no, I think that that's one of the challenges we have now is to try and bring these into new settings and to enable people who want to use them locally to have access to them and to get think about how to replicate the process that Lori really did so amazingly, and think about how other models might occur in these different settings.
So in terms of research, I think that we always have an ongoing project. Currently at the Rwanda pilot, and you can explain more than the specifics, but the idea of being able to be consistent over time to measure impact and efficacy. How can you make the process replicable to be part of being able to scale it? And obviously thinking about implementation, but also the evaluation, how this feedback loops go beyond design. It's also will have impact on how different communities can actually adopt it effectively. And one interesting question in terms of design, but I think also in terms of the actual impact, has to do with beyond the clinical setting.
Yeah, and I think that, for instance, in Rwanda now, the pilot is being led by a local nursing student in Rwanda. So different type of implementation and understanding of how those materials will be used in Butara. But it's an important question for us in terms of how we design the future of the project and how we work with new communities to enable them to be able to use these as they would like.
Other areas for the future obviously involve thinking about other treatments. This is obviously chemotherapy, but there are other treatments that are available that can help. It could be important to have information that is readable and is designed for literacy, or even pediatric care, something that been discussed for quite some time.
Right, I think that there's been interest asking us, and it's mostly largely been a bandwidth issue of can we design these for treatments for radiation therapy. There's a lot of fear involved with radiation treatment. And then in pediatrics, I'm thinking about how would we write these for kids who have cancer and for their families and for patients. So we think that there's a lot of value in thinking about how to work together collaboratively with patients and providers in low-income settings to design these for them so that they can bring value and really help improve patient support and engagement.
And also, as designers, we also saw opportunity very quickly of extending the actual form that this supporting process is taking shape. How can you involve the communities earlier in the process if you're designing a new solution? So it's participatory, but not very collaborative, and they participate, but they're brought with the solution. How can you bring them earlier on to actually participate in the design of that solution? So changing that part of the process. Also, thinking about different tools and touch points that would be involved. There are other physical things you can develop or design and have impact on the environment. Right now, it's a matter of resources, but it would be great for the design team to actually go to the field and experience the physical space. There are a lot of solutions that don't necessarily require printed material. There are many ways that this conversations can be supported, and I have time and resources to go and experience what it's like to be there, moving forward, helping the design team provide global oncology and their partners better tools and solutions. And then the cross-cultural aspect is really important, and I think is an interesting question. As designers, how can we bring interpretation besides the medical, clinical, and more, let's say, political aspects of this, socioeconomic, but how can design respond to that in a way that is both appropriate and localized, but also global and scalable? That's a huge challenge, and I think it's something that we're very interested to see how in the future it takes shape. So a little bit talking about some of the lessons and general lessons in terms of continuing work. And I think some of the big questions that were answered or are in the process of being understood is how can this work really impact cancer health at a global scale, as well as how can this particular process or these potential processes that are taking shape improve patient education, how to measure that. But then I think there is one fundamental question that has to do with how does patient education really mean in poor countries?
And I think that embedded within all this work in some ways an assumption and a very serious health equity moral issue that we want to respect the dignity of these patients. And I think that even though our initial attempt, and maybe it was naive, as we just wanted to provide some education, but embedded within that was really the respecting the dignity of those patients who are struggling with a life-threatening and many times often a terminal illness, and how to address that and provide them the most support we could in the limited constraints that we had. And I think the unexpected part was to think about, and Lori related to us stories about patients taking the materials home and speaking to their families about them, creating bonds between the care providers and the patient, creating bonds between the patient and their family and their caregivers, and thinking about how we can work to continue to improve those bonds and to strengthen that. I think that that is one of the questions about patient education. Beyond patient education, how do we really continue to respect the dignity of these patients while they face this very difficult journey and diagnosis?
So this speaks a little bit also back to the question of, and this is more from speaking as a designer or representing the design role in this collaboration process. Why do we get involved? I mean, most of our clients have been very large corporations or startups and dealing with technology projects, so why do we get involved in it? And I think one important aspect was really expanding the value of design, thinking about how design can contribute in a different way to affect change and actually have impact in communities that are not traditionally our target communities or our target beneficiaries. And also we thought, I think in that initial conversation, we saw a spark and a passion on a topic that we felt related to, but also the idea that they would value our work. So thinking about this idea of building disciplinary bridges that are not traditional. Designers thinking they have little sayings in industries, and you'd be surprised. Also thinking about the role of design really as a transformative power, and this idea that's been kind of this big buzzword about radical innovation, right, and transforming industries and changing. How can you have really immense impact with very simple and very sophisticated in terms of the discussion and elaboration, but very simple tools, booklet and graphic design. So how that role is more about synthesizing that knowledge, having your ears open and paying attention of everything that's being said, and becoming this sort of a catalyst, as we described before, and providing that in very practical ways, what are the practical implementations of those conversations. And then, in terms of a little bit of design leadership, in terms of more of a business perspective, how can we find projects also that are mission-driven and where a shared vision that's beside our own vision? How can we feed our own vision as a company from other partners and collaborators, where we see a lot of the commitment and passion. It's been really admirable to see the many volunteers that provide their time and their expertise with various schedules to make this successful, with seemingly very little reward to the personal. It's a lot of investment. So seeing that drive is very inspirational, and I think it fits into the culture of our company, like us, which are a very, very small team. So anyway, some of the reasons why this is very important, very interesting has been very interesting and very strong motivation for why we embarked ourselves in this journey with all and color. And I think last but not least, some acknowledgements of many of the individuals that have been part of this process. There's not a lot of time to describe who they are, but just to express that there's a lot of people involved behind this effort, representing different organizations, and they're very important to this process. So with that, I want to thank you and open the floor for some questions if you want to talk about it.
Well, so first I just want to start by saying this is wonderful work, and there's something so beautiful about the way you chose to communicate through very simple design, as you were saying. And I think I imagine even that in our own neighborhood here, there might be a need for that simplicity and that just that simpleness in the communication around cancer treatment and caring for cancer. And we all know that under the anxiety and sort of the emotional stress of a diagnosis like that, sort of our own rationality and maybe literacy goes out the window, and what you can take in and comprehend becomes so much more minute than you could if you were rational. So is any of this, for either of you, or all three of you, does it impact what you do here in our own neighborhood and how you
I think that's a really excellent point. I appreciate the comment. I think, now that you've mentioned it, I think it does. I think we've thought about, the co-founder goes based at Stanford, and she's talked to them about doing it in the local community. Again, but thinking about underserved communities. But I think the point that you specifically raised, in thinking about how this could impact patient care in general, I think it's an interesting point to think about how we design things for communities that are obviously impoverished, and what are the assumptions we've made there, and how are those assumptions translated to the patient experience in the U.S. and the richest country in the world. Because there are shared and common experiences of this, and I think it's, and if you know people who've been affected by cancer, and I think that you're absolutely right.
In these low resource settings, and I think also you'll see that in underserved communities here, there's not necessarily the same norm of telling your doctor what's going on with you, and so there's an element in there of this side effect reporter, and patients were saying, now I know I have to tell my doctor when I'm feeling sick, I have to come seek care, and that was the big lesson I took away from this, was always come seek care, always come talk to your doctor, and that's something I think definitely translates to educating patients here about, when you go home from chemotherapy and you have diarrhea for 2 weeks straight, you should call your doctor, because that's too severe.
I think from the design perspective, this falls into the framework of universal design or inclusive design, and we've been fortunate enough to have done 4 or 5 projects in inclusive design accessibility for digital technologies, for digital devices. But this is an example I put in the same category because you're designing for extreme conditions, low resource and low literacy, but that doesn't mean that doesn't benefit anybody. If you're able to explain things simpler, or you're able to let the phone speak to you because you can't see because you're driving. You don't have to be blind to benefit. Same thing, you have to be Malawi to benefit from this. So I think as a designer, it falls into that category of thinking about extreme conditions but extending benefit overall. And you make a great point, and probably an opportunity for mobile employees to think about extending the impact of these materials.
I have a question. You focused early on the knowledge gap and patient education. And if you resolved all that knowledge gap, what would be left in terms of compliance? And if you thought about compliance support within the materials?
Yeah, it's a good question. I think it's a complicated question in terms of what one means by compliance. And I think
Take their medicine, that's what I mean.
yeah, and I think that it's a great point. I think that we're actually there's a lot of research into this, and we know that patients in low resource settings who are told to take HIV pills every day do it better than we do it here. And I think that there are a lot of assumptions made about how well patients can comply or adhere to treatment. And I think that we often suffer from not giving enough credit to poor patients who have a strong desire to live with dignity. And I think that we can assess those things about compliance. But I think that in some ways, that's an offshoot of what we're trying as a first step.
Be the next step.
Yeah, and I think that's the next step. And I think certainly we could look at, does this change how patients, a number of different types of outcomes that you could assess. Again, I think that from a first step standpoint, our goal is really to try and provide education, to provide an area of engagement and support for patients on their illness. But that's a great point.
I would just add to speak to what is left once they know they need to come in, and it's not really that revolutionary or surprising, but it's the resources. It's patients need to travel 4 hours, and so many patients ask, do you have support for transportation? I have kids at home. I can't bring my kids here when I need to sleep overnight. What do I do with them? Do I need to work? Those are all issues. And just, I didn't mention this because it wasn't the topic of the conversation, but we did, when we were assessing patients' knowledge, we used a test, just kind of simple questions, what they knew about cancer chemotherapy before and after counseling. We did see a statistically significant improvement in patients' knowledge in the short term at least.
This is really great work and really challenging, especially sort of gauging, figuring figuring out how to deal with the cultural, like the visual piece of the depicting a person and making sure that they're relatable and all that kind of stuff. Which is not my question. My question actually was related to sort of, now that you have learned that this idea that patients didn't know to come to the doctor and tell them how they were feeling, like that sounds like it's an even bigger piece around like how some of those communities understand healthcare and how to take care of themselves and like that whole, has this experience led to any sort of thoughts about how to manage that piece of healthcare in developing countries? You know what I'm asking?
No, I think you're right. I think that's sort of embedded within this, is that we've made obviously certain assumptions, and what we're used to hearing from the shared, what we call shared decision making, your doctor said to you, so here are the options of what you could do. What would you like to do? What are your values? And what are your goals of care? I think that is a concept that you have to wonder, how well does that translate into various locations where there can be different norms, whether ranging from very paternalistic norms to other types of norms. And these are, as Carlos was saying, these are extreme situations where patients are facing living on $2 or $3 a day. And so I think that what we think and what we've assumed is that, trying to respect, thinking about what's right for the patient. And when I was in training, the lesson was always do what's right for the patient. And I think embedded in this concept is the idea of trying to do what's right for the patient. And that's creating a stronger bond between the patient and their caregiver and their physician or their nurse. That's helping create a better bond between family and that patient. And that's where we feel like that's moving in the right direction. And sure, there are the complex issues of the social norms and the ethnography of what exactly is happening. But I think that, not to say that we're ignoring that or that it's not important, it is important, I think. But I think that there is something universal about how to respect the dignity of the patient, how to do what's right for the patient. And maybe it is forcing some awkward conversations between providers and patients, and maybe saying, well, how do I really get to the hospital if it's 4 hours away? There is no 911, right? We don't have to call 911 here because that is not a reality in rural locations. And you're not going to have many places are not going to send an ambulance to you. So I think it's a very important question to tackle, and I think that we're hoping to learn from the process about how it works, and obviously how healthcare providers communicate with their patients and what they're trying to do is something that we'll try to continue to collaborate with them about figuring out who are on the right track with them online and what their goals are. But I think we've had to make some assumptions here, and I think we hope that we're on the right track.
Just to echo what Frank was saying about how important it is to build this relationship between the patient and the provider, some of the things that they're doing in Haiti, it's really inspiring how dedicated the team is to serving their patients. Everyone hands out their personal phone number and personal cell phone number to patients. They know who their patients are, and so if someone calls them, they immediately know, can remember who that person is. They do home visits to patients every so often to visit them in their community, even the ones, especially the ones that are 4 or 5 hours away, to see them in their home and just reinforce that bond.
I have one question. It seems to be that you are a great team in working, that you are really familiar together, and it's a non-profit project. And when I look at your question, could you, do you think it changes if you work together for profit projects? It's different. It's for my research. It's important to know.
I mean, I don't know. I've never worked for a profit, so I think that and doctors and healthcare workers are terrible designers. So.
But you're from a hospital.
Yeah.
And it's something like a business organization.
Right, absolutely. Right, and the goal then, at the end, still is measured in, are we taking care, are we doing the best for our patients, and are we taking care of our patients? Sure, there's business considerations in that, and there's value, obviously, in that, and are we creating value by what we do? I'll let Carlos address the question about, would it be different, you know, if we were a paying customer? I mean, I'll say that our goal is to figure out a way to begin to think about how to raise funds and raise some small amount of funds to support the work, and taking on this as a fundraising objective of ours to help support the development of whether it's new materials or adapting them to other locations, rather than have poor communities try to do that. So we were nonprofit Go decided to do that in partnership with these communities. But I'll let Carlos maybe address the question of how would it look if it were a for-profit venture?
So I think in many ways it would be very different, but the West Indies said it. I mean, I work in a for-profit organization, we're in design consultancy with our clients, and they have money for the projects, etc., etc. I think there's another aspect that's interesting, and I think it's a fluid in its own to design for social media. Once you have an idea of it's about defining value, and when you're being paid to provide value, it's an important way how you measure what you're being paid for and what you deliver. Here is a bit different because you're projecting value in different ways. Why would a for-profit organization be a non-profit endeavor? And it does several things in my mind. Besides the personal connection and commitment, which I think is fundamental, and the individual. This is all based on volunteers, and in many ways we are volunteering our work and our time and everything. So that's crucial. In that way it's different. But I think there's very important for profit organizations to open up to that, because what's really valuable, talking about value, is the level of commitment, the level of passion for the work, and that the drive that it provides. So a very successful for-profit companies manage to create a very, very powerful vision statement. And amazing CEOs provide inspiring visions. So people are willing to stay overnight and finish the project. And those are happier organizations. In many ways, that drives a lot of the way we work. So what I would say is that it will be different from the perspective of how the processes are managed, and because it's tied a lot more to very specific milestones where value is measured in terms of income. And I think here you're very different ways to measure the impact. One is the actual outcomes of the work, but at the same time the actual value it brings inside of it to actually learn and see the communities. Now we have a lot of very valuable information that maybe becomes a profit because of revenue, because of still, that's not how we do it, but there's natural halo effects on this. But I would say that the big difference is how you would manage the process and how you would see the value. One thing I would say that as designers, it's important, and I think something that's been encouraged by people in oncology, to be able to extend the resources. Because what we see is a richness of opportunities that we are serving very well with one solution, but there's so many ways. One expression of that support, and we see if there was alternative business models, sponsors, providers. So that's part of the design of the process. Maybe it's not that good in the future, but where are resources where different expertise can be combined with different sources or whatever to expand the capabilities. So that management is a different intensity. Or other than that, I think that the idea of social impact and value, and how you measure value both external and external, is where I would encourage all for-profit organizations to embrace, because it's a lot of important lessons too.
The insights that you gleaned in doing this work, the design principles that you developed, were obviously instrumental in making social impact, but they're probably translatable to a for-profit setting. Have you considered making the case that doing this work gets you to those insights and principles that would be valuable in a corporate setting in order to potentially either partner or get investment from for-profit companies for more social impact work?
I think that's interesting. What's natural, I think that's more probably the impact of oncology. I think there's a way, for example, being part of this conference, right, is clearly healthcare, global healthcare. This is a natural setting, but bringing Gloria and Franklin in the whole global increase setting and have this conversation in a different environment helps engage part of that. I think in the other direction is where can you bring building a business case where you find support for people that are involved in cash. You can talk a little bit about the opportunities for, I'm guessing, pharmaceutical companies or who can see this as a way of having impact as well as a corporation, but how you use the resources to fuel this at the same time, bring
question. I think there certainly is need, and we've heard from various pharmaceutical companies that are interested in the whole aspect of how do you really engage in patients in what they term as their emerging markets. And so I think that there is certainly lessons that we can learn from this and take that into making cases about how this could be expanded in a way that could be scaled at a level that serves interest for patients, but also for invested companies who have a product that they really want to make sure it's used correctly and that patients are supported sufficiently. Thanks for your great question.
Thank you.